Good afternoon everyone. Next topic that we are going to start with, it is drugs that are used in treatment of rheumatoid arthritis. So these are my contents of my presentation. That is, first is general consideration about rheumatoid arthritis. So it will include the pathophysiology or the pathogenesis of the rheumatoid arthritis. For more details, you can always refer to the pathophysiology book, that is by Harsh Mohan. Then second, pathophysiology of rheumatoid arthritis. So these first 2 points, they they have the recall value, that you should be able to recall the things that you have already studied. Then we are going to study the classification of drugs which are used in treatment of rheumatoid arthritis, and lastly we will be discussing category of the drugs which are used in treatment of rheumatoid arthritis. Okay, so general consideration about rheumatoid arthritis: it is a chronic, a systemic inflammatory disease which is predominantly affecting the joints and periarticular tissues. So when we say about rheumatoid arthritis, 3 words should come in our mind. That first is that it is always a chronic disease, it will never be acute one. So that is, over the period of time, this disease, the signs and symptoms of it will develop. Okay, then it is a systemic disease. Okay, so system will be affected because of it. Okay, then it is a inflammatory disease. So inflammation, classical signs and symptoms of inflammation, they will be evident in case of rheumatoid arthritis. In the name itself, it is arthritis. So as we have studied earlier, when the suffix is itis, it means that it is inflammation of, and as the word is arthritis, it is inflammation of joints. So in the definition itself we have said that it predominantly affects the joints. Okay, and also the periarticular, peri means at the periphery. Okay, so whatever tissue which is present at the periphery of the joint, it will also be affected in case of rheumatoid arthritis. Okay, so of all rheumatoid disorders, the rheumatoid arthritis, it remains a formidable disease, being capable of producing severe crippling deformities and functional disabilities. So when we talk about rheumatoid arthritis, it is not only the disease that is caused due to the rheumatic factor. There are other diseases also, like the rheumatic fever, but among all these rheumatoid diseases, the rheumatoid arthritis, it is the formidable disease. Okay, so more prominently this disease occurs, and also this disease causes the types of deformities that are crippling. Crippling, that means the person is not able to carry out his or her normal functions because of presence of rheumatoid arthritis. Okay, and also the function which is being played by these particular joints, that functions are also not carried out, or the person is not able to carry out these functions. Okay, so common clinical signs and symptoms, they are the pain and or the joint swelling. Okay, so morning stiffness at least for 1 hour, then fatigue, fever and weight loss. Okay, so these are all the common signs and symptoms that we see with this particular disease. So the disorder is more common in women and elderly persons. So its etiology is unknown, although the main risk factors, they include genetic factors and smoking. So we don't know exactly that what leads to this particular disease, but there are some predisposing factors they are thought of, like the genetic factors. There is some genetic predisposition is there. Also, in case of smokers, the cases of the rheumatoid arthritis, they are more. So it was thought that the smoking can be one of the factor for causation of the rheumatoid arthritis. Okay. So pathophysiology of rheumatoid arthritis, it is a clinical syndrome with many disease subsets. It comprises of three basic interrelated pathological processes. So the first process is the inflammation, second process is the synovial proliferation, and third process is the joint tissue destruction. So everything will start with the inflammation of the joint. Okay, then the synovial proliferation will occur. Synovial proliferation means what? That we will see in next few slides, and followed by it there will be destruction of the joint tissue, and that's why this particular disease, it is a crippling disease. It causes destruction of the joint tissue. Okay, so the earliest lesion is the vasculitis. So what is vasculitis? It is inflammation of the small blood vessels. The inflammation, it causes edema of the synovium. Edema means accumulation of excess of fluid in the synovium, and its infiltration with mononuclear cells, macrophages, lymphocytes, and the plasma cells. So what will happen? There is inflammation of the small blood vessels. Because of inflammation, what will happen? The fluid in the small blood vessels, it will exit the lumen and enter into the interstitial spaces, and because of this fluid there is edema. Okay, so along with the fluid there will be immigration of the mononuclear cells, that is neutrophils also. Okay, so along with the fluid the neutrophils will follow, the macrophages they will also exit, the lymphocytes they will also exit, and the plasma cells they will also exit the blood vessels. Okay, so once these plasma cells they enter into that particular synovial cavity, they will start producing the antibodies. Okay, so these antibodies they are of type that is IgG. Okay, so the other cells also they will have the certain effect. Okay, why? Because they have left their natural origin, that is into the blood vessels, and they have entered the new area or the new space. Okay, so as they enter into the new space, into the new area, they get activated. So it is like this. I will give an example of this. I will explain it with one small example. Whenever you are in your home, okay, you are not that alert. Okay, because you know each and every part of your home. Okay, but when you enter a new space, like if you go to some other place, and there you have gone for the first time, so that time you are alert. You don't know where the kitchen is, where the hall is, where the open space is, where the garden is. So you will be alert, you will be looking for all of these things. Okay, so just like that, our body inflammatory cells they work in this fashion only. But uh, what they do is that whenever they are in their natural space or natural origin, they are not that much alert. Okay, it is the routine that is going on for them. But when they enter into the new space, that is they exit the blood vessels and enter into the new space, they become activated or they become alert. And when they become activated, they start producing a variety of chemicals or they start releasing variety of chemicals. So similarly, something like this it happens in case of rheumatoid arthritis, as all of the cells, that is the mononuclear cell, macrophages, plasma cell, lymphocyte, they have exited their natural origin or natural space and have entered into the tissue space. They have become activated. So starting with the plasma cell, it starts producing the antibodies, that is IgG antibodies. Okay, then activated macrophages, lymphocytes and the fibroblasts, they produce variety of cytokines. Okay, so what these cytokines do, these cytokines promote further synovial proliferation and inflammation. So because of these cytokines, the synovial proliferation, that means more number of cells they do enter into the synovium, and also as these cells enter into the synovium, they don't just stop at entering there, they start releasing variety of chemicals, and these chemicals, they are nothing but the inflammatory mediators, and these inflammatory mediators, they end up causing the inflammation. Okay, tissue necrosis factor alpha, which is produced by activated macrophage like synoviocyte, it exerts powerful effects on the immune system, which include induction of pro-inflammatory mediators. Okay, so kindly remember, we have studied that macrophages can be of two types, wandering and tissue fixed macrophages. Okay, so tissue fixed macrophages, they are called by the name wherever they are present. Okay, so in the synovium, the macrophages which are fixed, they are called as the synoviocytes. Okay, so when they are in the blood, they are called as monocytes, and these monocytes, when they enter into the tissue spaces, they become macrophages. I hope you have you remember all of these things. Okay, and these synoviocytes, what they produce the tissue tumor necrosis factor alpha. Okay, and this tumor necrosis factor alpha, it has very powerful effect on the immune system, and as it has effect on the immune system, it produces variety of pro-inflammatory mediators. What is pro-inflammatory mediators? These mediators, they promote the inflammation. Okay, so next is classification of drugs which are used in treatment of the rheumatoid arthritis. So the first category of drugs, very common, that is anti-inflammatory analgesic drugs. We have already studied about these drugs, that is aspirin and the other non-steroidal anti-inflammatory drugs. Okay, so next drug is the anti-inflammatory drugs which have indirect analgesic action, and the example is the glucocorticoids. Okay, so also we have seen about this, and we will be studying in detail about the glucocorticoids in the next chapters to come. Okay, so these two groups, they act rapidly, they relieve the pain, and they control the inflammation. They thus help to improve and maintain the joint function. However, they do not halt the underlying destructive process. So they just give us the symptomatic relief, but the underlying destruction of the tissue is not affected by these drugs. Okay, so next category of drugs, and the very important category in case of rheumatoid arthritis, that is disease modifying anti-rheumatic drugs, in short DMARD. Okay, so examples of these drugs, that is Methotrexate, then Sulfasalazine, then Chloroquine, then gold salts, and Leflunomide. Okay, so these drugs, they don't have any analgesic or immediate anti-inflammatory effect, and they begin to act after 6 to 12 weeks. They remain in the body for a long time, and probably they modulate the immune function. Okay, so they arrest the basic destructive process in the joints and modify the course of the disease. They may induce remission. Okay, remission means what? It is symptom free period. Okay, understand the difference between the first category of drugs and the second category. The first category of drugs, they give us the symptomatic relief, but they don't stop the destructive process. What about these drugs, that is DMARDS? They don't give the symptomatic relief immediately, but they act on the destructive process. They stop the destructive process, and thus thereby they cause remission. Okay, next category of drugs, that is biological agents. This heterogeneous group, it includes complex protein molecules which are developed using molecular biological techniques. Their action is predictable, and it results from interaction with the cytokines or the cell surface molecules. Okay, so understand, in the pathogenesis of the rheumatoid arthritis, the cytokines are the ones that cause the inflammation. Okay, and what these drugs do, these drugs, they inhibit the action of the cytokines, and thereby they inhibit the inflammatory process. Okay, so the first drug in these biological agents is the TNF alpha blocker, that is tumor necrosis factor alpha blockers, and the examples are infliximab, adalimumab, and the etanercept. Okay, so when the suffix is MAB, MAB stands for the monoclonal antibodies. Okay, the next category of drugs is IL-1 receptor antagonist. So understand, all of these, they are nothing but the cytokines. IL-1 stands for interleukin 1 receptor antagonist, and the example is anakinra. Then we have third category of drugs, that is IL-6 receptor antagonist, and the example is tocilizumab. You should be able to correlate this drug, as this is one of the drug which is being used in treatment of the COVID, that is coronavirus disease. Okay, then next drug is the T cell activation inhibitors. So example is abatacept. Okay, the next is anti-B lymphocyte antibody. So lymphocytes, the plasma cells that enter or that proliferate in the synovial cavity, that are being neutralized by this. The example is rituximab. Okay, then we have tyrosine kinase inhibitor, and example is tofacitinib. Okay, the next category of drugs is immunosuppressants. As the name suggests, they suppress the immune responses. Okay, and the example is azathioprine, then cyclosporin A. So they can be life saving when severe vasculitis complicates the clinical picture. Okay, so let's start with the first category of drugs, that is anti-inflammatory analgesics. So these drugs, they act symptomatically, and they relieve the pain, they decrease the swelling, and they help to improve the joint movements. No non-steroidal anti-inflammatory drug is consistently more effective than any other, but some patients may not tolerate a particular drug. Okay, so when we consider all of the NSAIDs, we cannot say that this drug is more suitable than this one other, because not all of these non-steroidal anti-inflammatory drugs, they don't produce any consistent effect. So it is like trial and error method that we have to use. Okay, so we have to also see whether the patient is able to tolerate that particular drug or not. Okay, one second. So glucocorticoids, these drugs, they have potent anti-inflammatory action. So when given orally, they produce dramatic symptomatic relief which lasts as long as they are used. So they act by inhibiting the synthesis and or by suppressing the actions of inflammatory mediators. So what is their make of action? Is that inhibition of the synthesis or suppression of the action of the inflammatory mediators. So understand this, whatever cells that exit the blood vessel and enter the synovial cavity, they produce inflammatory mediators, and these inflammatory mediators are responsible for the signs and symptoms of this rheumatoid arthritis. So glucocorticoids, they suppress the action of these inflammatory mediators, and thus they produce their effect. Okay, so next drug is the DMARDS. So in that the first drug that we are going to see, it is gold salts. So water soluble gold preparations, that is sodium orothiomallate, then orothiosulfate and orothioglucose, they get deposited in the synovial macrophages in inflamed joints, and they inhibit their function. Okay, so we have seen that these macrophages, they produce the TNF-alpha, and this TNF-alpha has great effect, influence on the immune system, and thus it causes production of the pro-inflammatory mediators. So what these gold salts do? These gold salts, they inhibit the function of the macrophages, and they avoid all the following sequel. Okay, so they produce definite but slow and unpredictable improvement. Okay, so we don't know exactly that to what extent the improvement will occur with this particular drug, but we know that they are going to be effective in case of the rheumatoid arthritis. So pharmacokinetics of the gold salts, the sodium orothiomallate is rapidly absorbed and is distributed in the kidney, liver, spleen and other tissues, which include syncytial lining cells. Okay, so it is excreted in urine. The gold salts, they accumulate in the kidney and remain in the body for many years. Okay, so adverse reactions of the gold salts, the gold salts can cause dermatitis, then nephropathy, oral ulceration, then bone marrow depression, then peripheral neuropathy and the liver damage. So the incidence of toxicity is fairly high, and regular clinical and hematological supervision is mandatory. Gold toxicity, it is treated with prednisolone, that is 10 to 20 milligram per daily, and the another antidote, that is dimercaprol. So this dimercaprol, it is very common antidote which are being used in the toxicity of many of the agents like the mercury, arsenic, lead. Okay, so these gold salts, because of all of this adverse effect profile, they are now being rarely used. So next drug, that is chloroquine and hydroxychloroquine. Again, the most common drugs which you have heard in last few months, that is chloroquine and hydroxychloroquine. Okay, so these drugs are originally anti-malarial, so they are now they are repurposed for the use in case of the rheumatoid arthritis, just like that of hydroxychloroquine, which was being used in treatment of the COVID. This hydroxychloroquine, it is also used in treatment of the rheumatoid arthritis. So what these drugs do, how they act in case of rheumatoid arthritis, they are taken up by the macrophages and the lymphocytes. They inhibit phagocytosis process, they decrease T cell activation, and they reduce inflammatory cytokines, that is TNF alpha. So they produce moderate benefit in active rheumatoid arthritis and systemic rheumatoid diseases. So they have mild anti-inflammatory action and probably act as immunomodulators. Okay, so they are perhaps the best tolerated and relatively safe DMARD. So long-term therapy may rarely cause retinopathy and irreversible visual impairment. Hence, periodic ophthalmic examination during therapy is mandatory. So next drug in DMARD, that is Methotrexate. It is also called by the abbreviation, that is MTX. Okay, so this is folic acid antagonist which is given intermittently, and it appears to be highly effective and has acceptable long term toxicity and is very cost effective. Its action is probably related to inhibition of aminoimidazole carboxamide, that is AICAR transformylase, and thymidylate synthase. So thereby they prevent the neutrophil chemotaxis. So methotrexate, it is a teratogenic and it should not be used during pregnancy. So it should also be avoided in patients with significant renal dysfunction. Okay, so this is its mechanism of action, and by inhibiting a particular type of enzymes, it inhibits chemotaxis by the neutrophils. Okay, next drug, that is sulfasalazine. Okay, so the mesalamine component of the sulfasalazine, it inhibits pro-inflammatory cytokines, then immunoglobulins, the IgG, it is a immunoglobulin only, then COX enzyme, that is cyclooxygenase enzyme, and lipoxygenase enzyme, and thus it exerts anti-inflammatory action. The sulfapyridine, which is absorbed more, it reduces IL-8 synthesis and probably it inhibits angiogenesis. Angiogenesis is process of formation of new blood vessel. So as formation of new blood vessels is inhibited, the number of cells that are entering into the synovial space, they also increase, and thus it decreases the inflammatory process. Okay, so it is useful and is much safer than the gold salts in treatment of the rheumatoid arthritis. So the adverse effects include allergy, nausea, vomiting, and headache. Rarely neutropenia, hemolytic anemia, and thrombocytopenia, it may occur. So next drug is leflunomide. So it is a pyrimidine synthesis inhibitor and is as effective as sulfasalazine in decreasing signs and symptoms and slowing the radiological progression of the rheumatoid arthritis. After absorption, it is converted to active metabolite which inhibits RNA synthesis and cell growth, and it also prevents T cell proliferation. It remains in the body for very long time, that is up to 2 years. The adverse effects are diarrhea, reversible alopecia. Alopecia is balding. Okay, then skin rash, then hypertension, and the hepatic damage. Anaphylaxis and Stevens-Johnson syndrome, they have also been reported with the use of Leflunomide. The drug is carcinogenic, that is, it can cause cancer, and it is also a teratogenic drug, that is, it is contraindicated in pregnancy. So next drugs, that is biological agents. The first one is TNF alpha blockers, and the example is infliximab. Okay, so this is chimeric monoclonal anti TNF antibody, that is 75% human protein and 25% mouse protein. Okay, so that is its composition. And anti TNF antibody means what? Whatever TNF alpha that is being released by the synoviocytes, that it is neutralized by these TNF alpha blockers. The cytokine TNF alpha, it is actively produced at the synovial sites in rheumatoid arthritis. So this infliximab, it binds to the TNF alpha with high affinity, avidity and specificity. So it is well tolerated in doses used. The most common ADR are headache, nausea, rash and coughing. It may precipitate respiratory tract infection, including the tuberculosis. The next is IL-1 receptor antagonist. An example is anakinra. So it is a recombinant human IL-1 receptor antagonist and is given subcutaneously. So it is used in combination with MTX. MTX is methotrexate. So it is also used in inborn syndromes which are associated with high IL-1 production, and also for systemic forms of the juvenile inflammatory arthritis. Let me be very clear with you in this regard, that these cytokines, they are as such, they are not produced in the body. They are not like normal components of your bodies. They will be produced only in case of inflammation or in some kind of infections. Okay, so production of cytokines is always associated with some kind of pathological abnormalities. So that's why we need to inhibit or we need to antagonize the effects of the cytokines to stop the progression of the disease. Okay, so next is IL-6 receptor antagonist, and the example is tocilizumab. So it is an anti IL-6 receptor blocker and is effective in patients who are not responding to DMARD or anti-TNF agents or both. So understand, these drugs, they should be used only when the patient is not responding to either of the drugs which are mentioned. Otherwise it should not be a first line of therapy. First line of therapy should be DMARD or anti-TNF agents. Okay, so it is administered intravenously. Its ADR, they are similar to that of anti-TNF agents. In addition, it may increase total and LDL cholesterol and cause neutropenia. Okay, so next is T cell activation inhibitors. The example is abatacept. So this is a fusion protein of cytotoxic T lymphocyte antigen 4, which is linked to IgG1. It prevents T cell activation and it lowers serum concentration of inflammatory cytokines in the rheumatoid arthritis. Abatacept can be combined with DMARDs but not with TNF alpha inhibitors or anakinra. Okay, so next is anti-B lymphocytic antibody. So rituximab is a monoclonal antibody which is selectively depletes CD20 B lymphocytes, which play a role in the autoimmune response and in the chronic synovitis which is associated with rheumatoid arthritis. Okay, so whatever B lymphocytes that enter into the synovial fluid, the neutralization of this B lymphocyte, it is carried out by these particular drugs. So next is tyrosine kinase inhibitors. So example is tofacitinib. It is a first oral Janus kinase inhibitor which is approved for the rheumatoid arthritis patients who had inadequate response or are intolerant to the methotrexate. So this Janus kinase enzyme, it is a signaling mediator in various immune pathways. You must have studied about this Janus kinase enzyme. If you remember the receptor families, there are three receptor family. First one is ligand gated ion channels, second one is the G protein coupled receptors, third one is enzyme linked receptor. Okay, and in enzyme linked receptor, second example which is given, which is of the receptors that respond to the cytokines, and in that we have the JAK-STAT pathway. So in that, JAK stands for the Janus kinase. Okay, so tofacitinib, it prevents phosphorylation and activation of the intracellular mediators which are involved in immune response and inflammation that lead to the joint destruction. Okay, so this phosphorylation, as you must be knowing that phosphorylation is responsible for the activation process. Okay, so they prevent this phosphorylation and this activation of the intracellular mediators, and thus they prevent inflammation that lead to the destruction of the joint. So adverse effects of this drug include diarrhea, nasopharyngitis, headache, hypertension, hypercholesterolemia, then opportunistic infections, then neutropenia, lymphopenia, then anemia, and increased liver enzymes. Okay, so this drug is metabolized by the CYP3A4, which is an enzyme present in the liver. Okay, then next drug is immunosuppressive agents. So various alkylating agents like azathioprine, then cyclosporin A, cyclophosphamide, they have been used to induce remission in the rheumatoid arthritis. So these drugs, they act as suppressors of the B and T lymphocytes. However, they are less effective and they are more toxic. Okay, so last is the goals of the rheumatoid arthritis therapy. So what are our aims, objectives when we are treating the rheumatoid arthritis? So the current goals of therapy of rheumatoid arthritis, they are the suppression of disease activity as soon as possible and reduction of symptoms, then arrest of the erosive and functional joint damage, then improvement in laboratory indices, then induction and maintenance of long term clinical and radiological remission after cessation of drug therapy. So what should be our first aim is that we have to reduce the signs and symptoms which are associated with rheumatoid arthritis. Once we reduce the signs and symptoms, actually these signs and symptoms, they cause very much problems to the patient who is suffering from the rheumatoid arthritis. That's why we have to first of all focus on the reduction of signs and symptoms. Once we reduce the signs and symptoms, simultaneously we should be working on the arresting the joint damage, because if we don't arrest the joint damage, if we only work on the symptoms, then this condition is going to be worse. Okay, and it should at one point of time it should go so much worse that with the anti-inflammatory drugs also we cannot suppress the symptoms of the rheumatoid arthritis. So that's why at the simultaneously we have to work on arresting the erosive and functional joint damage. Then third goal is to improve the laboratory indices. That means whatever laboratory values or indicators that indicate the rheumatoid arthritic condition, they should improve over the time. Obviously, as we are giving the drugs, that is our aim, that it should improve. Okay. Then induction and maintenance of long term clinical and radiological remission. That means even after we stop the drug, uh, we should have achieved the long term clinical and radiological remission. That means symptom free period should be there even after we stop the drugs. That should be our aim of our therapy. Okay. So with this we have finished with the chapter, that is rheumatoid arthritis. Thank you.